Dr. Jhund from Glasgow, who will discuss high risk of morbidity and mortality in patients with heart failure.
Thank you very much, Professor Swedberg. Ladies and gentlemen, thank you very much for coming along today. As mentioned, the title of my presentation is The High Risk of Morbidity and Mortality in Patients with Heart Failure, and it's under treatment with evidence-based therapies in the UK. These are my co-authors, and these are declarations of interest or conflicts. So, as you've heard already today, heart failure is a common problem. About 1 in 5 people will develop heart failure over their lifetime, and 15 million people currently suffer from heart failure in Europe. And as you've also heard from the previous speaker, the patients with heart failure frequently are admitted to hospital, and they have high rates of death. They die very often, unfortunately. But a number of therapies have been shown to reduce morbidity, as in hospitalizations, and mortality, i.e. deaths, in randomized controlled trials, and are recommended by all the international guidelines in the treatment of heart failure. Unfortunately, however, such therapies are still potentially underused in clinical everyday practice. So we aim to describe the management and outcomes of a cohort of community-dwelling individuals with heart failure in the UK. And we did this by looking at just over 14,000 patients with a code for heart failure in the UK's General Practice Research Data Link, the CPRD dataset, and this records information on patients in primary care from their general practice and a representative sample of general practices throughout England. We looked at these patients and looked at what medications they were being prescribed and whether they were on target daily doses of evidence-based therapies as has been defined by the clinical trials and are stated in the international guidelines, in particular the ESC guidelines. And the drugs that we use in heart failure to reduce morbidity and mortality are ACE inhibitors, or angiotensin receptor blockers, beta blockers, and mineralocorticoid receptor antagonists. We defined those as reaching target doses, those who were within 25% of the maximal doses stated in the guidelines. So if you were on 80% of the maximal dose, you were said to be on target dose. So let's just have a look at the patients who we looked at. And as you can see, their mean age was 79, so very similar to the previous presentation. 48% were women, I think, and 49% in the last presentation, so very similar. And if we look at a number of their characteristics, like their blood pressure, their heart rate, their renal function, you can see that actually if you look at other clinical trials or other data sets of patients with heart failure, they're very similar in their composition. A subset of them had a natriuretic peptide level, and you can see this was raised in most of them, indicating that these were patients with probably symptomatic heart failure. And then just draw your attention to some other comorbidities down here at the bottom of the table. Some of them in this data set, you're given a diagnosis of heart failure. Obviously, heart failure, as many of you will know, comes in 2 forms, that with reduced ejection fraction and that with preserved ejection fraction. Most commonly, we think about reduced ejection fraction when talking about treatments. And to define that further, a number of patients in the data set had a code for left ventricular systolic dysfunction, i.e. reduced ejection fraction heart failure, and that was coded in 44% of the patients. Now, that's not to say that only 44% had reduced ejection fraction heart failure, but that's the number in which it was coded, and we had documented evidence of their ejection fraction. And 16% had asthma, and I'll come back to that in a minute. And again, if we look at the morbidity and mortality and the number of hospitalizations and the number of deaths in this cohort, you can see that they're very similar to other published cohorts in other clinical trials. There was about 15 per 100 patient years, and they died at a rate of 15 per 100 patient years, which is very similar to recent trials of patients with heart failure. They were also admitted to hospital very often. 31 per 100 patient years was the rate there, and 14 per 100 patient years of heart failure hospitalizations. And the median length of stay, as we have been discussing just earlier, was 8 days with a range of between 4 and 16. There's also quite a big burden of non-cardiovascular hospitalizations in this cohort. The rate was 49 per 100 patient years, and the commonest non-cardiovascular causes were respiratory and gastrointestinal diagnoses. So let's look at the treatment now. And I've split this in the blue bar for all the patients in the cohort, over those 14,000, and we've given in the red the data for those who had a confirmed documented diagnosis of reduced ejection fraction, and you can see they're broadly similar. So 86% were an ACE inhibitor or angiotensin receptor blocker. 50 to 56% were on a beta blocker. 25% were on a mineralocorticoid receptor antagonist, and 25% on digoxin. And we'd be looking to see everyone is usually prescribed an ACE inhibitor or a beta blocker. So we would be aiming if we were treating them by guidelines to have 100% in both of them, and a much higher percentage in a mineralocorticoid receptor antagonist. And if we look at the proportion of these people who are actually receiving those target doses as defined by the guidelines, you can see that only around 40% of patients were getting that target dose of ACE inhibitor. Only 20% of those who are getting an angiotensin receptor blocker were getting the target doses defined by the guidelines. And only 20% of the patients who are receiving a beta blocker were getting the target dose. It's much better for mineralocorticoid receptor antagonists. A very high proportion of them were getting the target doses defined by the guidelines. Although we have to remember that only 25% were on a mineralocorticoid receptor antagonist to begin with, but those who were on it were getting the right dose. So in conclusion, patients with heart failure are at a high risk of hospitalisation and death. But despite this risk, the use of evidence-based guideline recommended therapies is low, unfortunately. And to combine with this, the drugs are prescribed at suboptimal doses. To move this forward, we really must understand why prescribing rates are lower if we are really to ultimately improve this poor morbidity and mortality in patients with heart failure. Thank you very much.
Thank you for this interesting information, which is in accordance with the previous findings. For example, Dr. Komashta has done studies in Europe and supporting this, the suboptimal treatments in general. So there is a message for you to help us to distribute. Any comments from the...
Exactly, is really in keeping with the previous presentation. We are missing in the patient, and although we know that average age was 79, I can imagine that some of these patients may not tolerate most of what we consider absolutely necessary drug, but still very poor implementation of what we know is vital in this patient. Even when we are prescribing this drug, we are not giving the dosage that we know it works. I think this is an important message there is a lot of to do for the physician, both in the hospital and in the primary care, to intervene, to educate, to improve this adherence and rate of prescription.
Yes, I can only agree and echo those sentiments. I think we really need to try and educate everyone to get them onto these drugs and up to the guideline recommended doses. And as you mentioned, there may be reasons why the patients can't take the drug, very good clinical reasons. For example, asthma, as I highlighted, 20% had or 16% had a diagnosis of asthma, which would be a contraindication to beta blockers, but it still doesn't explain why only 50% were on a beta blocker.
So, yeah.
Hi, Ben Spencer from the Daily Mail.
Hi, Ben.
Hi. You, in your press release, in your footnote, you kind of acknowledge that there's a bit of a drawback with your study, in that you're looking at guidelines for reduced ejection fraction, but the cohort you're examining, you don't know how many or if a significant number have reduced ejection fraction, or, are you comparing apples with pears?
No, I think that's what I was showing with that graph there, that you had the red bars were people with left ventricular systolic dysfunction, i.e. reduced ejection fraction. So those are the ones that had a confirmed diagnosis. And I think whilst there will be a proportion have preserved ejection fraction heart failure, and that doesn't quite apply to them, we know from other epidemiological studies in the UK that the prevalence of heart failure with preserved ejection fraction shouldn't explain all of these low rates. Okay.
How different are the guidelines for the two different forms?
They are different in that we unfortunately don't have at the moment any medications which reduce morbidity and mortality in heart failure with preserved ejection fraction, although studies are underway. and the use of ACE inhibitors and beta blockers and mineralocorticoid receptor antagonists are not recommended to reduce morbidity and mortality. However, in preserved ejection fraction heart failure, we often use these drugs to treat other comorbidities as well, such as high blood pressure, hypertension, which go along with heart failure with preserved ejection fraction. So there is a lot of overlap, but they don't reduce events.
Okay, sorry, if I could just have one more question. For those 44% of the cohort had confirmed reduced ejection fraction.
That's right.
So those are the bars in red.
That's right.
Your top line claim of 80% are not getting the optimal treatment. Can you apply? Does that 80% also apply to those patients who have confirmed reduced ejection fraction?
Yes.
Have you analysed that?
Let me show you. Here, so for example, if we just look at the red bars, they're the ones with confirmed ejection fraction. A lot of them aren't getting the medication that we've indicated. So 14% are not on an ACE inhibitor or angiotensin receptor blocker, 44% are not on a beta blocker, and 75% are not on a mineralocorticoid receptor antagonist. And those with reduced ejection heart failure should pretty much usually be in all three of those. So we're missing a lot of patients.
So, but the 80% top line stat, do you think that is that also applicable? Have you actually calculated that?
Yes, we have. So if you look at combinations of the three combinations, and maybe I apologise, I should have probably put on a bar of all three. You know, people being in all three is extremely low.
Yeah, thank you.
Okay.
Hi, Laura Donnelly from Daily Telegraph. I was going to ask about the same points, but just so on that final point. So the figure is exactly the same for both groups when you combine all three, or would it be slightly short of 80%?
No, I mean these are it's kind of difficult. So and these are the details that we'll hope to bring out in a publication later on. But obviously, I don't have huge amounts of time to do it here today. But often you start from a baseline of an ACE inhibitor or angiotensin receptor blocker plus a beta blocker. And then you move on, and if the patient is still symptomatic, you add a mineralocorticoid receptor antagonist on top of that, okay? And for the vast majority of patients, you actually do. But working out how many are actually needing a mineralocorticoid receptor antagonist is often very difficult from these routine data sets.
Sure.
You can look in a sort of broad, general fashion as we've done here, but as I was trying to allude to in the conclusion, there may be very good clinical reasons why the patients are not on all three, and that sometimes is not easily recorded in these types of data set. And I think that's what we really need to go on now and try and figure out is, well, how many of these patients are appropriately not receiving the medication and how many are inappropriately and have been, it's a missed opportunity.
But I think we could add that with the present new guidelines, there is really a recommendation that in all patients with reduced ejection fraction, all three agents should be considered, in combination. So, and here is obviously that there is a sub-therapy and better treatment could be offered. And I think you can help us with an important message here.
Just a word of caution and information for the press. Besides the drug we have also some other important way to improve the outcome of the patient with heart failure, which you did not discuss at the moment, but you should know that and you should count on that, because the devices are something which is here to stay, which are widely discussed in this meeting and in heart failure meeting, and which are becoming more and more important in the treatment, especially for the toughest form of the heart failure patients.
Okay. If there are